على شهادة الدكتوراه في التخطيط الاستراتيجي للخدمات الصحية من جامعة لانكستر من المملكة المتحدة.
السلام عليكم ورحمة الله. صوتي واضح للجميع اللي موجودين الخلف؟ إن شاء الله بإذن الله. بإذن الله نفتتح جلستنا الثانية. في هذه الجلسة بإذن الله سيكون معنا من المتحدثين وآمن منهم عند سماع اسمائهم الصعود إلى المنصة الدكتور سعود محمد الصمعان من مستشفى التخصصي Managing Director والchairman of Allergotic Company. كذلك معنا الدكتور عادل المرشد. الدكتور عادل المرشد Advisor to the Minister of Economy and Planning, Assistant Professor Emergency Medicine, University of California, San Diego, USA. Welcome aboard. And then we have Dr. Mohammed Abu Rashed. Dr. Mohammed Abu Rashed, you may have met him during the first session. Dr. Mohammed is the advisor for the on PPP for the Minister of Bangladesh, for the President of Bangladesh. Dr. Mohammed, please, and we will start the session with a presentation for 20 minutes. It will be presented by Dr. Mohammed. So, Dr. Mohammed, could you please proceed?
Hello, Mr. Thank you once again for letting me speak in and talking about PPP as a whole. Essentially, it's a leverage and privilege for me to be here and talking about PPP and how it works. Today, I'll be talking about PPP models, and particularly if the guys who have attended the first session, the PPP UNEC health standard that we have developed as part of expert panel. So, just to give you an introduction, the PPP health standard took us 20 global PPP experts 1 year for developing the standard, and PPP by default took hundreds of years to formalize to a process where it is now in terms of models, in terms of deliveries, in terms of technicalities. So all these 100 years things I have to summarize and pass it through to you. Sure you have understanding and experience on this in 20 minutes. So it's like I have to cover the English channel in 20 minutes. So I'm willing to swim as much as I can before I get on. So friends, we are talking about PPP, and I think there has been a long discussion and debates, and I'm sure it will happen down the line more. PPP is essentially a component of PSP. So the PSP program that Health Council is working with the World Bank. So PPP, if you look at the potential involvement of private sector in with the government, so which is PSP. So it can be as simple as a management contract. Up to a level, it goes to a complete privatization. But please understand, when we talk about PPP, we don't talk about privatization. We don't talk about that the government is selling off its assets or properties to private sector. It's rather the other way around. Government holds the right of the asset, and generally it comes back to the government, and government works as a regulator in terms of the inter-PPP deal. So PPP is somewhere where we get both of our people, public and private sector, in between, in this middle grade. And PPP is something not new. And you will be very surprised to know, worldwide, more than 87% country is working on PPPs. Worldwide, all the development partners, it's more than 50 who is actively working on PPP. So, my dear friends, PPP is not a choice anymore. It's a necessity, because regardless of how rich your government is, we are talking about infrastructure. Infrastructure is huge capital investment. The government alone cannot do it. Don't have the leverage. So that days are over. You need the private sector guys to step in, to help you out in doing your infrastructure, to help you out to provide the clinical services for you. Maybe down the line, you have a trust issue, you have confidence issue with the investor. Maybe you start with basic services, then you possibly tend to go to a more advanced level. So I covered this. So the PSP journey may start from a simple contracting out to up to a complete privatization. So in the entire journey, in between, where both of the government and the private sector has its own role and responsibilities, as a partner becomes the PPP. So we bring it to a concession model, we can bring it to a management contract model, but it has to have a, one, infrastructure arrangement. Two, it has to have a profit motive. So it cannot be a charity by the private investor. So you cannot have a charity. It has to, I was speaking to my friend during the break, and he was saying, I want my granddaughter who is pregnant to be treated right now, right at this moment, to get the best service. And I cannot go 5 kilometers, 3 days, or something like that, to go to a government hospital. So I need the best treatment, immediate treatment, immediately. So my dear friend, we have to have PPPs, and in the PPPs, we take an arrangement where both public and private sector comes together, do their roles and responsibility as part of the contract. So if you look journey of PSP from management contract to a complete divestiture or the privatization, the role becomes, if you look at the journey itself, the more you go up, the government becomes more regulator and less of service provider. For let's take an example of management contract. For a management contract, it's all about government show. The private does a very little job. But if you talk about divestiture or the complete privatization, it just sells off the share. So in between, the concession, BOT somewhere, you have a fair balance of regulatory activities and service providing activities in terms of regulation and in terms of actual delivering the service, and which comes to the jurisdiction of PPP. I talked about why PPP is required. It's about the demand not being met, and it's about the opportunities the private sector can help in terms of capacity building, in terms of actual service delivery, in terms of the real expertise, in terms of especially in terms of investment. So, and I told you before, I'm supposed to talk about the PP models, and trust me, there are so many PP models in healthcare. You talk about franchising, you talk about contracting in, you talk about contracting out, you talk about social marketing, you can have numbers of models. And to make sure you don't get slipped, you don't get bored during the presentation, I have put an annex and I have described how each of these franchises works out. Please remember, I have 20 minutes. So there is a detailed annex. I have described in details how individual these models, the Starbucks franchisee, the contracting in, contracting out, I have described in detail. So please take your leverage after the presentation to look at it, and if you want to know a bit more about the presentation. But what I really wanted to talk about is these emerging models. So if you look how the think tanks, the development partners, and many of people like so-called PP experts have been advising, is a very interesting mix of quality versus cost. So I think in a very interesting way, if you look at the Asian region, if you look at African countries, all the emerging PP economies, you will find this cross-subsidy model that we discussed in the first session is something really happening. It's happening in PPP models. People are going for medical college PPPs. All these things is basically all about to ensure the private sector guy, the poor guy, makes his return on investment. He gets his money back. It's not a charity, but essentially regional diagnostic centers. So I think in Saudi Arabia you have also already done some level of radiology services being provided to private sector, or you are working on it. Cross-subsidy models, especially for infrastructure development, and essentially the medical college and district level hospitals are emerging in terms of PPP in the economies, in the developing PPP economies. So in either case, whatever the model is, generally when you talk about PPP in health service, we particularly talk about two streams of activities. One, the infrastructure development. Two, the actually service delivery of clinical services. So when we talk about infrastructure development, maybe the private investor does the building, he constructs the building. Maybe he provides equipments, maybe from GE, Philips, Siemens, and he maintains it. So in either case, when it's about scope 2, when you service, you provide the infrastructure, it is more or less on an availability-based payment. As long as you make this infrastructure available to the general people, as long as you ensure the contract being developed, you made this obligation as part of your service delivery in terms of actual hardcore infrastructure you being developed, finance and operate, is available to the people, to the service providers and the regulator, you get this model. Is basically you form an SPV, and I will be covering this in a short while. This is on an availability-based payment. But the clinical services, and this is somewhere when we talk about the PPP practitioners, PPP, we get a bit more details when you call output specifications. So when in a public sector project, you tend to look at the detailed technical specification. Maybe you say, okay, I need a MRI machine with 1500 resolution. I don't know, just I'm saying this, I'm not an MRI guy. But in that you do, when you do your public sector hospitals, you do this detailed technical specification. But when you do PPP, you go output specification. You actually do not get into details of what he will do in terms of supply. But you tend to do it what he will deliver in terms of output. Maybe he needs to deliver 80% of his total bed to be occupied by general people. Maybe he needs to ensure the mortality service rate comes to 0. Maybe he needs to ensure that a patient comes and he is immediately attended within 5 minutes of his admission. So this is the level of output specification you tend to go when you talk about a service delivery model. So in a scope 2, it's based on an availability payment. In a scope 1, it is based on your output. I am a great fan of the cross-subsidy. And I'm quite sure you have realized this by this time. I keep saying the cross-subsidy, keep saying the rationale being, this cost versus quality argument, where in many countries in the UK, in many countries in Saudi, even in Saudi Arabia, you provide the basic health services to general people free. Now, what about you have thousands, millions of people to be treated? You have limited number of hospitals. And again, you don't want to be queued, possibly, if you're an older people, you don't want to be queued in the hospital for 2 hours. You want to get your granddaughter is pregnant. You need to be treated immediately. You can't travel that far. So you have to have your hospital being ready with you right at this moment when you need it. So this brings a very interesting structure, and I have discussed this in the first session, that where actually your proportions payment is being subsidized by the wealthy people. So a portion of the premium that you receive from the wealthy people is being used for treating the poor patient, and the government through its annual budget allocation, I guess from the Ministry of Health, they provide the same services to this operational deficit. And this is how the cross-subsidy model works, and this has been a great phenomenon, success in many countries worldwide in terms of actual PPP health delivery. In terms of contractual obligation, I told you before, we need to make sure the guy who wins the bid is segregated from actual delivery, and that's why we develop an SPC or SPV, special purpose company. Now, all the contracts, this actually passes through the winning bidder to the actual company being developed, which has no connection with the winning bidder except from this shareholder agreement. So all the dividends, all things, this pass through. Then this PV has is contract being signed with different lenders, authorities, and actually the contract is traditionally signed with SPV. So once the winning bidder is awarded, he is issued a letter of intent, and as part of the condition precedent, they need to do a SPV first. And SPV signs the contract with the regulator, with the contracting authority. Dr. Tragis, please stop me if I am running out of time, but I'll be very quick to finish this. So these things, this slide I've covered, what are the basic level of output specification generally you tend to look at for a private sector PPP projects. Everyone is doing healthcare PPPs, everyone. So again, I don't want you to get sleep. I don't want to get into details on who is doing what, but a lot of people are doing a lot of things in PPP. And again, I have put another annex for you to see what is the success story and what is the story of different governments have done in healthcare PPPs in a separate. But you know what? If you want to promote PPP in healthcare sector, regardless if not in the healthcare sector, in any sector, in your country, you need to have a central agency. And again, if it is a healthcare, you need to have a central agency championing the PPP in healthcare. And I was discussing the other day with the Health Council, and you have to be a think tank, you have to be a regulator. If you want to be that central nodal agency, if you want to promote healthcare PPP in your country, you cannot be a service provider and act as a regulator. So there will be conflict of interest. So this central agency, so let's say for sake of discussion, for healthcare, it is Health Council. Health Council needs to act as a strategic level to screen the right projects are being selected. He needs to ensure the project is bankable. He needs to ensure when the tender is floated, every stakeholder is accounted, has been discussed. Accountability issue is ensured. He needs to involve all the stakeholders, be it the private sector, be it the donor agency, be it the World Bank, ADB, everyone is getting involved. And essentially, that's the central role of a central agency. And this will lead you to adopt a PPP framework. And I'm quite sure you will see the momentum getting on. And you will see this session is not the end of the entire momentum. I was speaking to my friend 10 minutes back, and he was saying, we keep having this level of type of conferences and nothing happens and so on. Trust me, I hope this time it's about Health Council and this will be taken forward, inshallah. So what do you really do when you become a champion, you want to promote healthcare PPPs in your country? I generally see it from three perspectives. One, you have to have a very good PPP project pipeline. You have to have a very good policy level structure. You have to have a detailed due diligence before you launch the project into the market. And essentially, you look into the very details of the project in terms of requirement, in terms of bankability, in terms of financial viability and so on. And when again you go to the tendering process, you have to make sure everyone, you do the market sounding, you do investor promotion, you do pre-bid meeting. This will ensure the project bankability. So maybe you have put so many clauses in the contract, which is not bankable. It has to go to the lenders. And lenders will come back to you saying, hey, I don't agree to this contract. I don't agree to these clauses. You have to change this. This gives you the leverage to make a PPP contract bankable. You have to cover all this compensation, dispute resolution, rights and duties, concession period, change in law, force majeure. So, my dear, we are talking about a relationship for 20 years, 30 years. And we just can't prepare a contract like 5 days. So it has to be really thought through. I give you an example, very interesting example. Please, I'm apologizing if this is something you don't agree. PPP contract is something like your marriage contract. Let me explain why. Because in your marriage contract, most cases you do, right? So you have your roles and responsibility for both the partners. In fact, you have even the termination scenario, the compensation payment. This is exactly what we do in our PPP structure. So guys, everyone who are married here, we know PPP very well. But you know what? If you want to promote PPP in your country, you have to have fun. You have to set aside fun. And I discussed with before with the Saudi government that this is the fundamental. You want to promote PPP in your country, you have to have fund for project development. You have to have fund for that viability gap funding. You remember in the cross subsidy model, and you have to have funding, or you have to leverage your resources to make sure you have financing component. You have the lending part, the debt equity, the debt, 80% of your total project cost. I think I'm end of my presentation. So we have from United Nations Economic Commission for Europe in Geneva, we developed a PPP health standard, and I really promote that you look at it. I'm very happy that Dr. Tagrid and team has looked at it. So what we have done in the UNESA health standard is basically we said before you do a PPP, you have to have a integrated approach to healthcare policy in PPPs. So you make sure whatever policy you adopt for healthcare does not conflict with other sector standards or your overall global role. So yesterday I was again discussing with someone, so they're saying that even for investment, you have your own regulations. So investment from coming to Saudi, investment going from Saudi, you have your own regulations. But understand, in PPP you will have direct FDIs, you will have even the local investments. So your PPP policy has to incline with your central policy, and maybe in many cases what has happened, it happened in Bangladesh, it happened in India, you may need to change, you need, for welcoming PPP at a broader level, you may need to change your central government policy to ensure that, because you don't have a choice, you need private sector investment. So if you need to make it large, you have to make it large. Then we talked about the delivery plan. How do you select and prioritize a PPP project? So you must have a very, very standard mechanism that first, can you take any project you like? No, you don't. So okay, you have to have a very straight mechanism how you select a PPP project to be taken on a PPP route. Then you should have a very standard project pipeline based on which you will draw down individual projects and float it to the market. We talked about the procurement governance arrangement. This is all about the accountability we discussed in the first session. How you make sure there is no corruption in the tendering process. Now, let me tell you something very interesting, and I am very happy as an advocate of PPP of raising this point. So I was meeting around 2-3 years back, the Deputy Prime Minister of UK, and he was saying public sector projects, and even actually I was having discussion with PFI between the difference between PFI and the PPP. So in a public sector project, let's say for the sake of discussion only, and this is completely sake of discussion, if you have a public sector project, and so it's an EPC contract, and the project cost maybe, let's say $100 million. But the 5 bidders, they submitted the bid. The lowest bid is $1,000 million. What can I do about it? What is your institutional mechanism to prevent this? There's an open competitive bidding. So for the sake of discussion, there went something wrong in the evaluation process for the sake of discussion. And you award the $100 million deal to an EPC contract for $1,000 million. It can happen. At least for a theoretical perspective, it can happen, right? The evaluation committee, we are those guys, okay, you give me 500 million, I give you this project. So let's say, for the sake of discussion, let's say. Now, let's move to a PPP. How this gentleman is going to recover his fund if he wants to bribe me to take a project of 100 million for $500 million, and he gives me, let's say, $100 million, I become a rich guy, I buy Rolls Royce. So I get $100 million, but how this private sector guy gets this fund being recovered? He gets this fund recovered through using the toll. So the more he does this left and right, the more he is in trouble. If the hospital charges more than the traditional charge, you will go to the next hospital, you go to a private hospital, another hospital. So by default, PPP promotes zero corruption, and that's what we have captured in our PPP health standard. So I talked about the healthcare institutional recovery. I'm sure I'm running out of time.
Yeah.
I'll be very close.
Thank you so much.
And we talk about the project feasibility and viability, how to make sure a project is being viable. And the last slide, we have talked about how we ensure that each of the individual stakeholders are being involved in terms of actual delivering of the PPP transaction. So actually floating the tender into the market. So thank you very much, ladies and gentlemen. I appreciate you.
Thank you so much, Dr. Mohammed, for this interesting presentation. And if you allow me to start the discussion with the panelists, and then we will open up to the audience questions. So the first question that I will pose to Dr. Mohammed, you have presented to us the different kinds of PPP models, and it is something we do realize in public sector that the PPP initiatives are something that market drives to us. We find ourselves as a public sector obliged to invite the private sector towards financing and operating and also delivering the services with us. So given this context, how do you think we can structure the PPP transactions in healthcare delivery?
Right. So I think I have already during my presentation covered, and even in the first session. So this is about the same question that in the first session they asked about the cost versus quality. So in a cost versus quality structure, typically we adopt few mechanisms. Number one, generally we tend to go for an availability-based payment. So for infrastructure delivery, you will not go for clinical services, but for you do the infrastructure and you make payment to the private investor based on his actual delivery. But essentially, coming back to your main question, I again tend to go, generally in such situation, we do the cross-subsidy model.
So the cross-subsidy is the perfect way to structure these PPP transactions.
Yes, I think so.
Yeah. So, but for us as a public sector, our current regulation and our current institutional, is it, Dr. Adil, ready for these kind of cross-subsidy models and also the other models that were presented?
Sure. So thank you very much for giving me the chance, and I really would like to extend a thank you to Dr. Mizroor for actually holding this. I think it comes very timely. So let me start by introducing myself a little bit. So my name is Adil Rashed. I'm the lead advisor for the Council of Economy and Development Affairs on the subcommittee of private sector expansion for the health sector. So I've had a stunt in the Ministry of Health for about 1 year, and during that time we helped coordinate the 6 themes of transformation in healthcare. One of them is around private sector participation. The engagement so far has been with the Vision 2030 and the National Transformation Plan has been around 3 entities primarily that we engage with in healthcare. One is King Faisal Specialist Hospital, and the other one is the Ministry of Health, and the third one is with the Ministry of Education. Now, there are 2 streams going on. One is the piloting stream, and this is actually a call out for all the people in the private sectors and others, is that if you see a compelling value proposition for the government around access, quality, and very importantly, cost reduction, or cost enhancement, or cost efficiency, or effectiveness, or utility, then you just come and actually present to us. And we in the Ministry of Economy and Planning, under the Health Reform Coordinator function, is we actually channel these proposals to our colleagues in the Ministry of Health or other respective entities. So this is a very important message that I would like to actually share with the rest of the group. The second thing is we have an entire work stream now with all the ministries on overviewing the regulatory framework in the government. Now, prior to the Council of Economy and Development Affairs, there was the Higher Council for Economy. And during that time, there was a strategy that came out around how the government should approach the private sector. Now, that was a strategy, but did not include a lot of regulation or language that would actually make it amenable to transaction contraction. So what we're doing now is that we have an ongoing exercise to inform the different streams in the government. And primarily, most of the time, it comes down to 2 things. One, is would the government offer sovereign guarantees? And then the second thing is what would be actually our arbitration in case we go into a legal conflict or issues. And then the major issue around finance. So what makes talking about privatization complex and exciting is at the same time you have a backdrop of reform in the government. So we are reforming our legal spectrum in healthcare, we are reforming our finance, and at the same time we're asking the private sector to come out with proposals. So we have an ongoing stream. This is a call out for a lot out there who actually been familiar with the government work to come to us with suggested pilots. We've already entertained topics around radiology, labs, pharmacy, and even medical services. Hope that answers your question.
Well, that answers the question, but in the first part of your answer, you mentioned that you're working closely with King Faisal Specialist Hospital and the other two entities. But then I'll leave it to Dr. Saud to discuss how complex, and it's one of the challenges that the healthcare sector faces is that we are multi-sectorial industry in terms of healthcare. We're very complicated within the healthcare industry itself and also intrasectorial, also with other sectors. That's one of the challenges that we face. It's not a matter of dealing only with the three entities. We will face more and more entities. And we in the SHC, we not only deal with King Faisal Specialist Hospital or the Ministry of Health. We have people who are from the private healthcare sector itself and from the other spectrum of the other sectors in the government itself. So that's one of the issues that we want the Ministry of Planning to be dealing with, because we have this burden on our shoulder. And I'll leave it to Dr. Saud to also elaborate on this point and also to discuss with us and to present to us what are the challenges that you think are facing us when we apply the PPP contracts or the PPP models that Dr. Mohammed has presented to us in their presentation. Please.
Thank you, Dr. Reed, for inviting us to this forum. And with regards to the challenge, first of all, I think the most important challenge is the concept of PPP. There's misconception of the PPP. We need to differentiate between PPP, PSP, POT, and also outsourcing. All those, it's coming under PPP, and so it's need to be clarified. I think Mr. Rashed tried to elaborate on this during his presentation, but I think it's need more work to elaborate in the differentiation between each mechanism. The other challenge is lack of policy. Dr. Adli mentioned that they are working on it, but it's really important to have a policy which clarify the PPP even for the private sector, so they will understand what's the role of the private sector in this transformation. Maybe the third challenge, especially in the healthcare, is the capacity and geographic distribution. Saudi Arabia is very huge. We have different area which is underserved, and it's not potential. For revenue generation driven. Projects. So this area needs to be taken care of it, review it, and find out how to serve such area. There is other other challenges is the corporate financing. How to finance such project. Dr. Abu Rashid, I think he gave an example. If we have a land and we want to operate it, build a hospital, operate it under PPP, how to finance it, how to get a mortgage. Because it's the land that's owned in the end by the public sector, while the operator is a private sector. So also this, I think, one of the main challenges. We have challenges with the operator themselves. If we go to the private operator within Saudi Arabia, we have plenty of polyclinics, hospitals, but if you look to a real operator, you will find them very few cannot take all the burden of PPP. So there's how to encourage international operators to come, because most of the local operators are small, the big operators in the hand, maybe 3 or 4. Most of them are family business. So this is, I think, a big challenge in Triple P, implementing Triple P. Also, we have a challenge, I think, which is, I think, it's one of the most important challenges, is the medical care financing. How to finance those, how to cover the patient. And the law of Saudi Arabia, all the citizen is eligible for free treatment. If we go to Triple P, you need to introduce fee for service or insurance or whatever. So how will we solve this issue? Is it through private insurance, national insurance program? This, I think, it's need to go parallel with the initiative of Triple P, because if we not solve it, it will not be attractive for the private sector to engage in any operation. At the end, the Saudi citizen need a free service, either through national insurance program or private insurance or whatever. And the last point is I will mention it and I will close my mouth, it's the potential of corruption in the Triple P.
Yeah, definitely. That's definitely one of the important points that we tackled on the first session, which is the accountability, and also Dr. Mohammed has also touched upon it in his presentation. But going back to Dr. Mohammed, you mentioned that we need to finance, Dr. Saud mentioned that we need to finance the healthcare service delivery. And if we look for ways through the Triple P mechanisms, this will mean that we have to deal with contingent liabilities. How do you think the government will manage these contingent liabilities if we adopt these Triple P models?
Well, that's a very, very interesting question, contingent liability. And worldwide, the most advanced PPP countries are also struggling of defining contingent liability, rather than management is way too far. So there has been some success stories in Brazil, in Spain, and they have done this, and Sri Lanka is something that they're very interested in looking at. I'm also part of this support program. So if you look at contingent liability, so it can be of two types. So from the contract, it can have an explicit contingent liability, like if you need to have a provision that the government will provide annuity payment to the service providers or the infrastructure developer. So yearly, let's say $5 million. So that's an explicit. But you can have that Dr. Adil said, the sovereign guarantee. The sovereign guarantee says if the project fails or if there's a force majeure situation, the government will provide $100 million to the private sector to make the losses, to cover up the losses. So this is not covered, and you don't know whether this will happen. So these two things, explicit contingent liability and implicit contingent liability, generally what many countries have done, Dr. Tagwid, is basically they make a probability assessment. And so something like, so the Sri Lankan, in the way I have been supporting the Sri Lankan government, I have adopted a model, this is called Black-Scholes, following the Black-Scholes model, if you are familiar with Black-Scholes model for financing. So the Black-Scholes model allows and looks at different scenario of the potential failure of the contract and then provides an weightage. So let's say an earthquake can happen, and let's take the example, maybe 1% of possibility. So if an earthquake happens, so each of these individual scenario is assessed, then is weighted through a generally I prefer a Black-Scholes model, and then you try to address how much contingent liability a particular contract have for a particular project. And then what you do is basically you add up all your PPP projects and add up all the contingent liability arising from different PPP contracts to get an annual estimation of contingent liability. This comes to your point, the management. So generally, I think it is wise to have the central bank or Ministry of Finance to set aside a fund which may not be used, but immediately can be mobilized when there is an occurrence happens. So I think a contingent liability management should be taken forward on a policy level, and I think neutral agencies, neutral financial institutions, especially I believe much in central bank, should have an active role in management and accounting and management of contingent liabilities.
Yeah. So Dr. Adil, picking up on the comment that Dr. Mohammed has said, do you think that as we as a government and the healthcare agencies themselves, are they prepared to take the PPP targets within their budget, annual budget allocation? Are we considering what Dr. Mohammed has said? Are we considering the PPP contracts within it? Are we pushing the the government healthcare sector itself?
You're spot on. Yes, there is an opportunity. We have an exercise now being undergone with multiple entities within the health sector and also the government, and we call it the OPEX exercise. So what we're looking at here is, it's a known fact across multiple health systems that their healthcare for the last maybe 20 to 30 years have incurred a large number of inefficiencies. And we believe that there's a huge number of waste in the health sector that we have in Saudi Arabia. So this could be an opportunity for the private sector entities who are familiar with what's going on in Saudi Arabia, to take examples for generic drugs versus none, or using different, what they call a physician preferred item, or standardization of clinical pathways. And you can actually recognize the savings that you can come back to the government and say, this is a well monetized return on investment for the government. Now, could you do it within the budget allocations? And the answer is yes. So His Royal Highness Prince Mohammed bin Salman, under the Council of Economy and Development, created the Bureau of Spending Rationalization. And this is a unit under SIDA, and it's hosted within the Ministry of Economy and Planning. And the goal اللي هو موضوع ترشيد الإنفاق. So this OPEX exercise is being undergone under this bureau, and with it we can come to opportunities where the private sector comes in and propose something that would be cost saving and improving access and quality, that we can channel it through, and there will be an immediate exemption activation. Obviously, if the case is overwhelmingly convincing for the government. And there is precedence for these in the past. So I think this is a very important case for a lot of people in the private sector and it's worth reiterating that we want you to come to us with a value proposition that shows a cost saving. And you come to us and say, one of the examples we had was hemodialysis versus peritoneal dialysis. It's very clear that you have a drop in about 30 to 40%, sometimes 50% in cost. Patient satisfaction, mortality and morbidities are actually reduced. So why are we not actually doing this more forthright? So I expect a consortium to come together and then give us a proposal. And there are numerous examples of this across the spectrum. I just want to add one thing, that Saudi Arabia, the look for the private sector in the past has been rather a good one. If you look at the American operator that came in the 1970s and started our flagship hospital at King Faisal Specialist Hospital, then transferred over to the National Guard. So we do have some centers of excellence that have been created with the private sector, but then you find others in the opposite end.
Yeah.
And one last point too is, I just want the team to be cognizant that the public-private partnership, do not forget the public part of it. That we are very, very cautious about increasing high level of complexity into the government procedures and our ability to actually engage with the private in a trustworthy and predictable way.
Yeah. What I want us as planners to be cognizant of is actually, besides being prepared financially for the PPP models and for the contingent liabilities, for allocating PPP, for considering the PPP in our annual budget, is the resources issues. If we do not solve the resources issues, then we will face other dilemmas, and which is the point that I want Dr. Saud to please elaborate on the resources issues that we have and the challenges that we have in the private sector as we are the frontliners. If we have these plans coming and all these written in papers, are we able, in terms of resources, to materialize them to the ground? I want you please to elaborate on this issue.
Yes and no. If we go to the private sector, the more flexibility in the private sector can encourage the resources to come, the local and international. But this one will make a high competition in the resources, which will increase the salaries. among those who's working in those projects. But on the other hand, it will increase the productivity and efficiency. So you will need less resources to operate if you compare it with the, government hospital. But also it maybe will affect the quality, because the private sector is revenue-driven exercise. So this will affect either the quality and some specialty, which is not revenue generation, not generate revenue like psychiatry, emergency medicine. You will not find it attractive for private sector.
So, but and also one very important point related to the resources issues is that if we create policies for PPP, and if we work on it from from the Ministry of Planning, or with the Ministry of Planning, and with all of the other sectors, the human resources will definitely be affected by the labor themselves will be affected by these policies. We have to expect labor dynamics to happen along the way. How are we dealing with this? And this is a question I'm not expecting you to answer, but this is a question that we have to put on the table and discuss while we are developing the plans, while we are developing the policies or the PPP laws that we have to work on in the future. I must add this point just to what you have said. So thank you, Dr. Soudan. Thanks to all of you. I'll now start with the audience questions. Please, Dr. Abdullah, please. The mic.
I think you can hear me. I'm glad that my friend Dr. Adil is here. I think we it's wise to have a PPP unit within CEDA, and I don't mean PPP for healthcare only. I think PPP period, because we're pushing privatization. I think it's wise to have that. I think our goal in the healthcare system has to be the triple aim that the IHI talks about, which is better health, better care, and lower cost. So along the cost, and just to mention a couple of examples where there's a lot of waste, is at the CAPEX and at the OPEX. So the Ministry of Health, and I hope that my friend in the projects in the Ministry of Health will not be upset with me, but I don't think it should be in the business of building hospitals. I think the Ministry of Health should be about health. And I think building hospitals should be kind of outsourced in a BOT format. I don't agree with the DBOT, because I think the Ministry of Health and the government should hold on to the design, because this is how you can make sure that you have a safety design that you hold the private sector accountable for. So this is a huge area for waste, and as we all know, if the CAPEX is expensive and the structure is bad, then the OPEX would be very expensive throughout the lifespan of the organization. And this is what happens. You end up with a very high cost at the CAPEX and a very high cost as an OPEX. If you just move towards BOT and come up with a clear safety designs for different categories of healthcare facilities, not just hospitals, and then you can get into long contractual agreements with the private sector, 20, 25 years, and have the Minister of Health kind of make sure that it gets done properly.
Thank you, Dr.
Just one other area, I think, because I feel very strongly about it, which is the supply chain management. I think most healthcare systems spend 30-40% on medical supplies. I don't know if we have the numbers here in Saudi. This is a huge area of waste and harm for patients. So it's not just waste in terms of money. Patients are getting harmed because they don't have access to timely access to quality consumables. And consumables, I mean everything, medications and devices. So this is a good area where we need to outsource the whole supply chain management to the private sector. These are the two areas where we can get a lot of bang for the buck. Thank you.
Thank you so much, Doctor. So it's very clear that the higher leadership have given the marching orders of separating the regulator from the provider. And the Ministry of Health is actually working on separating these two elements. And I just agree with you that there's a huge number of waste that we have, that could be an opportunity for the private sector to come in. I see this private sector participation with the PPP or others as really an intervention to improve our AAA, like you mentioned, you know, healthcare and cost. So no, I'm completely aligned.
Can I take a question, please, from this side? Yes, please.
Since since we are sharing the same infrastructure, from the private point of view, when you give, like Dr. Abdullah says, the management for a company and the labs for the others, and we are sharing the different projects, do you think this example will lead this hospital, for example, to achieve the best? I mean, with the presence of this different categories, with the different reporting system, with the different... Another question, for this central PPP, don't you think that should be neutral? Not a part, because you are the second part of me. So when we have a conflict, we should go to the neutral part. Okay? Thank you.
So should I take it?
Yeah, please take this question.
Let me clarify my friends from Ministry of Health who said the design issues. I agree to disagree. So generally when we talk about design, I agree in a point that the design should be given by the government. But this is a discussion where we are having is detailed design versus broad design. So government, when it floats the tender, they give the broad design. So they limit the design principles and they limit the standards. The government has its own standards in terms of construction, in terms of health delivery. But you need the private sector to come up with detailed design for innovation. So this is to address your query. And absolutely, I fully agree to the second question that the central agency should be neutral. And it has to be essentially not a service provider. It cannot be a service provider. And to avoid COI, a conflict of interest, he must be a regulator than the traditional service provider.
Thank you so
If
much.
you allow me, I will just comment on the first question. Yeah, I do agree that the management of a hospital should be one, instead of fragmenting the service. Maybe there is some area which you can outsource or do it in different model, but the main service in the hospital, like lab, radiology, and medical service should be within one organization.
Thank you so much. Another question, yes, please.
دكتور خالد سبيل، الحقيقة في قصة صارت في وزارة الصحة للأسف، يعني واحد من مسؤولين وزارة الصحة كان مسؤول عن كل الرولز والريجوليشنز اللي تطبق في القطاع الخاص، هو الشيرمان اوف ذا كوميتيز فور ذيس رولز، والله غضب عليه وصار في القطاع الخاص وتورط في كل القرارات اللي صدرت في وزارة الصحة. فالحقيقة دائما نقول إذا في شيء لابد يكون applicable affordable وإلا ما تمشي الأمور. الدكتور أبو راشد تكلم عن إنه demands is one of the things that go to PPP, also the funds. I think إحنا الآن جينا في funds, we don't have much funds. That's the reason now we are going to these models, because we don't have enough funds for the healthcare. الدكتور سعود تكلم الحقيقة، شكرا كنت واضح. Claims not for the private sectors, claims for the government sectors and their regulations. We are requesting this several years ago. Give us a strategic planning. You want the private sector to be having a role in healthcare sector or not? All they are deviating under study and study and study. So don't blame the private sector. Private sector, I think they are ready to participate in these things because this is their rules. The contracts, I'm sure that contract is very important, but always we think for the patient. The problem that we have a conflict of interest. The people who are now doing this regulations, they are the same people 20 years ago. The same concept is going back, and I talked with you previously before you were talking. Really, we have many rules and it's not being changed. I think I am really proud about Dr. Adil. The understanding of this, the new concept is very important for us, but please, we need transparency. The private sector, the end user, don't have that much information. All the information that you have in your offices and your committees, it's not yet been announced. How you expect from the private sector to react? So really we are now in a dilemma. We would like to have a clear vision to understand what's going on, what you need from the private sector, and keep the competition with transparency.
I just want to follow up on your point. The private sector has not done a good job in representing themselves. And honestly, I've met with multiple entities that represent the private sector, and then later on you find out that they have less than 1% equity in the total health investment. So there's a burden on you to create a trade organization of health providers in the private sector, whether it is in the hospital level, the clinic level, the supply chain level, and come with one voice. So I go to different Saudi chambers, commerce chambers, and each different views you find in different chambers actually. And so honestly الشغل مبعثر مع العلاقة مع القطاع الخاص، واعتقد ان في فرصة كبيرة لكم في القطاع الخاص انكم تجتمعون وتوحدون اكثر من ناحية تجون suggestions for the government من ناحية regulation or payment to others.
Please, please.
Dr. Khalid, I'm not blaming you rather than telling the fact. I mean, this is the existing situation. I don't think the local operator is ready, I mean, to have those big, projects under PPP. Still, they have potential, they have a lot of chance, but if you go through all over the kingdom, I'm sure all the local operator cannot do it.
بس أعلق على الدكتور عادل رد عليه. بس الحقيقة الدكتور تتكلم على إنه القطاع الخاص، إحنا القطاع الخاص فعلا يعني تكلمنا مع الأخوان في تحديث الأنظمة وقدمناها واعتمد من أحد الوزراء، وبعد ما تعين وزير ثاني ألغي كل شيء ورجع كما كان. فالحقيقة إحنا بادرنا، لكن القضية إنه لابد يكون كمان الأذر صار.
خليني أعطيك مثل، يعني أنا بتكلم مع قطاع المستشفيات. Who do I talk to؟ من أكلم؟ أنا أبغى أتكلم عن المستشفيات في القطاع الخاص. Do we have like a hospital Saudi private sector association that we can actually sit down with them? لا مجلس الغرف حتى بعد اللجان حقتهم حجينا وحضرنا معهم. And we want to have a robust structure that we can actually interface with, call on constantly, to be in touch.
إذا تسمح لي القطاع الخاص وتحملني شوي. في تجربة ناجحة عندنا، ليش يعني احنا ننظر للسابق؟ الآن القطاع الخاص مع التأمين يديرون ثلث سكان المملكة، السعوديين وغير السعوديين. تجربة القطاع الخاص بالتأمين، ولا عندنا أي مشكلة، لا مع البروفايدر ولا مع شركات التأمين. والقطاع الخاص ينتظر هذه الكيكة من سنوات، وهو ready to accommodate all you need. But we didn't know what you need. That's all.
Please, yeah. Microphone is in the back.
رفيق خفاجي من البنك الإسلامي للتنمية. I'm Rafiq Khafaji, Business Transformation Manager in the Islamic Development Bank. I just want to elaborate on what Dr. Hausawi mentioned, that OCM, Organizational Change Management, should be in the private sector hand. And this is totally opposite of the picture. It should be 100% owned by the government, because the main and the focal point in this area is the sponsor. And we all know the sponsor of these activities, His Royal Highness Prince Mohammed bin Salman, and he came 2 hours on NBC just for the awareness part. So it is totally in the government hand. So it cannot be in the private sector hand, and they cannot handle it. Each one will handle it in his way. They can be part of it, but not handle it. Thank you.
Can I just elaborate?
Yeah.
I mentioned.
Sorry, Dr. Abdullah, there are so many hands rising up from the back. I'll take on. Please go ahead. Yes.
It's a BOT. It's not. I didn't say that the private sector would own it.
I'll just take a question from the back. Yes, please.
Actually, thank you so much. The question is to you. Once you were talking about.
Stand up. Sorry.
No, thank you. You are talking about the private sector, and you giving name to the private sector. Is there a tarif for a private sector? Do you include the third sector, which is the non-profit organization? Are those people important in the PPP structures or strategy or whatever?
I hope you will stay with us for the third session. We will be tackling this on the regulatory and institutional landscape, and we will be able to answer your question further, but the answer to the question is yes.
Okay.
But if you stay with us for the third
Sure.
session, Dr. Tammy will tackle this. We'll take a question, yes, from the back. Yes, please. It's good for you. Yeah, gentlemen up there.
السلام عليكم جميعا. طبعا احنا نتكلم عن القطاع الخاص والاخوان كلهم من القطاع العام اعتقد. القطاع الخاص احنا عندنا فيه مشاكل تمر بالقطاع الخاص، بس اغلب اللي في القطاع العام يتكلموا عن القطاع الخاص وكانهم اوصياء عليهم ما يسمعون صوته. فاحنا عندنا مشاكل في القطاع الخاص. هل كرمتوا جمعتوا مستثمرين في القطاع الخاص سمعتوا مشاكلهم؟ هذا رقم واحد. اثنين، القطاع الخاص يحتاج إلى تسهيلات تمويل بشكل ميسر. اثنين، ثلاثة، نحتاج إلى هيئة وطنية لتنمية الشراكة بين القطاع الخاص والعام. عندنا أربعة، في بعض الأنظمة تمر عليها عشرات السنين عشان نغير مادة واحدة، مثل بند مشاركة الطبيب السعودي للمستثمر في القطاع الخاص، عندنا 13 سنة عشان نغير مادة واحدة. الآن مطلوب منا استشاري سعودي أو استشاري غير سعودي في كل مجمع طبي، مع عدد الاستشاريين الموجودين على مستوى يمكن القطاع الخاص لا يتجاوزون العشرات، لأن هناك ندرة في وجودهم. في رقم 5، في أنظمة موجودة مثلا لمشاركة القطاع الخاص مثلا في النقل الإسعافي، مر عليها الآن سنة من توقيع الدكتور الهيازة على النظام. لنا الآن نحاول ناخذ ترخيص بالنقل الإسعافي للقطاع الخاص، برضو إلى الآن ما وجدت. يعني لماذا لا يسمع صوت القطاع الخاص ويعمل مجلس الشراكة؟ شكرا.
خلينا بس نتحدث عن موضوع This is the realm of Ministry of Health. Okay, the Ministry of Health is the regulator, is the provider, and is the channel of the payments. So حنا وزارة التخطيط, we're actually aligning with different entities on this transformational journey. We understand the grievances that's actually being presented here, and they echo constantly every day with us, and we're looking into them, and we look forward to actually more and more engagement. ناحية تكوين قناة وطنية, we are in the process of creating a center of excellence under the Ministry of Economy and Planning and the Council of Economy and Development to look onto how do you actually advocate, how do you provide oversight, whether this entity is going to actually translate all the way where we can have a capital market authority, this still needs to be determined and actually voiced over prior to making a decision.
I'll take one last question from you, please. Yes, go ahead.
Okay.
Just go ahead, please. Yeah, sorry about this.
معذرة، عثمان أبا حسين استشاري في القطاع الخاص. عندما تجد الأنظمة الدولة تستدعي أو تطلب من الاستثمار الأجنبي دخول المملكة العربية السعودية في الاستثمار. أنظمة وزارة الصحة تقتصر فقط على المستشفيات، مع أن في خدمات أخرى استثنت زي الغسيل الكلوي والأشياء، لكن أتيت لأنظمة المنشآت الصحية تجدها فقط للمستشفيات و100 سرير فما فوق. ثانيا في أنظمة زي اللونج تيرم كير ما فيها وضوح في الأنظمة موضوعة كيف ده، فتخضع إلى الشخص الذي تراجع في الوزارة يعبر كيفما اتفق، فما في وضوح في الأنظمة ولا في شفافية أو كمالية في الأنظمة. هذا سؤال.
شكرا جزيلا. دكتور عادل, would you want to follow up on this? The regulatory and the institutional.
أتفق معك أخوي، وأشوف إن في فرصة كبيرة إن إحنا نشتغل مع بعض. مجلس الشؤون الاقتصادية أرسل للغرف إنهم يعطونا آرائهم في شغل كل ربع سنة quarterly, and we want to actually hear your opinions. وطلع خطاب من المجلس في صدد هذا الموضوع، ونتمنى أن هذه تلحق بالخطاب اللي بيرسل من مجلس الغرف السعودية. اعتقد احنا بوصية على القطاع الخاص، بس اشوف كثير من الاطباء السعوديين اللي يشتغلوا في القطاع الحكومي يشتغلون في القطاع الخاص, and they generate a lot of the revenue for these hospitals, and these are actually, a lot of them could be actually government employees. أعتقد القطاع الخاص needs to organize more and have their concerns available through access online, through actually creating venues to actually come hear what they have to say, their opinions, and really need to have an advocacy. It's not really about a piece of paper that gets sent, or we really need to have full engagement, and it should not be only from the public side, it's also a collaborative between the two partners.
Thank you so much, and please I invite you to the third session after the lunch break. We will discuss how we try to integrate the public and the private sector. So thank you very much, Dr. Mohammed, thank you very much, Dr. Saud and Dr. Adil for joining us in this session, and I'll leave it to my colleague.
تفضل الأمين العام بتكريم المشاركين في هذه الجلسة. دكتور سعود سمعان. دكتور عادل المرشد.